having invited me to talk on posterior segment injuries. When I specifically asked Dr. Natarajan what aspect of posterior segment injuries you want me to cover, he suggested traumatic retinal detachments. So anatomical issues at the time of injury can also influence the way the retinal detachment develops and is managed, and the issues which occur afterwards. So these are corneal damage, the integrity of the eyeball, presence of choroidal detachment, serous or hemorrhagic, vitreous blood admixture, disruption of the anti-segment, disruption of the retinal architecture, and injury to optic nerve and macula. All these have an influence on what happens subsequently, what do we do, and the outcome of the treatment itself. The anatomical issues at the time of definitive surgery, I use the word definitive surgery when this is a surgery we are planning to ultimately fix the retina and give the patient useful vision. That's what I mean by definitive surgery in the posterior segment, which we roughly do about 10 to 15 days after the primary repair is done. At that time, the definitive issues would be the clarity of cornea, because the cornea is very hazy and doesn't permit you to see the vitreous properly. You may have to combine with the penetrating keratoplasty. So you need to plan that accordingly. Status of the lens, whether you need to remove the lens, or you can retain it, or you can remove it and put an intraocular lens, or you just ignore the lens and make it aphakia. All these have to be decided at that point of time. Damage to the iris, whether you don't worry about it or you want to repair it at the same time. Ciliary body damage like cyclodialysis cleft to be repaired at the same time. And then incarceration of the intraocular structures, how you manage them, etc., etc. We also have to deal with the systemic issues that complicate the surgery, such as the cranial trauma resulting in neurological issues, and an ocular trauma that was not properly managed, which is a sclerocorneal wound which was not repaired properly, has much worse prognosis than something which has been well sutured, because of the obvious reasons that the vitreous is in the wound, it stimulates a lot of fibrosis. This fibrovascular ingrowth causes a lot of damage to the retina. So if the initial globe restoration is not adequate, somebody who has explored the sclera partly, but the actual scleral rupture is going all the way back, they didn't bother to suture the posterior part, is again having a difficulty. You again have a difficulty when you manage the retinal detachment. A delayed definitive surgery, again for obvious reasons, induces a lot of fibrosis, a lot of distortion of the retina, with gliosis in front and behind the retina, making the surgery a lot more difficult. Add to it lid trauma and adnexal trauma, that makes it even more difficult. And an improper lid cover, because the lid is torn and not repaired properly, you have a problem. So a word about closed globe injury and retinal detachments. This is often caused by retinal dialysis. Chronic detachments are more common with multiple demarcation lines, because these are eyes with vitreous which is still a gel at the time of injury. It's only subsequently, slowly, it undergoes liquefaction, and hence the amount of liquid vitreous available to cause detachment is very little, and then slowly it progresses. It's mostly managed by scleral buckling. The vitreous is not detached, but you can also have large retinal tears, almost a giant retinal tear, occurring especially in eyes with predisposition, high myopic eyes, etc., wherein a blunt injury can actually precipitate a giant retinal tear, not a dialysis. So these are acute detachments and mostly managed by a pars-plana vitrectomy approach. And I'm here talking about just pure detachment of retina, rhegmatogenous, without a coexisting damage to the choroid, RPE, etc., etc. Let's talk about open globe injury and detachment issues. Again, you need to talk about all these parameters when you decide about what exactly you're going to do during surgery. As I said, definitive surgery is done about 7 to 15 days after the primary repair. The reason is that gives you the optimum time to interfere without allowing fibrosis to take the upper hand. At the same time, give you an opportunity to have an intact globe which doesn't keep on leaking during surgery. The wounds are a little more watertight. The patient had a time to recover from the initial trauma and the post-traumatic psychological disturbances. The patient's relatives also have time to discuss with you what are the options, outcome of management, etc. You also have time to investigate the patient properly, a proper CT scan, MRI, etc., etc. And by giving them steroids preoperatively, you make the eye a little more quiet, less risk of postoperative retinal detachments and PVR, etc. The status of the retina is not always evident preoperatively. If you have an eye filled with blood, choroidal hemorrhage, subretinal hemorrhage, etc., you don't know what is the status of retina, how badly it is damaged, and whether it is really architecturally intact to regain vision or not. So in these cases, you just take a chance, operate, and tell them in advance that you may or may not get back any useful vision. So the first steps during surgery is that you assess the clarity and the need for a combined PK, where in preoperatively you anticipate, we tell them to keep a cornea ready. And in most cases, you should always keep a cornea ready if you think even as an iota of doubt that you may require a corneal grafting. It's always good not to use the cornea if it's not required, it's okay. And then you of course drain the suprachoroidal blood as the first thing by using these trocar cannula systems, and then form the vitreous cavity by injecting fluid through the anterior chamber. And then once the choroid has gone back, only then you place the infusion cannula, assuring yourself of its location intravitreally. There's difficulty in introducing instruments in these cases because of the serous and hemorrhagic cilio-choroidal detachments, presence of cyclodialysis cleft, presence of anterior loop traction in the retinal periphery, so your cannulas and instruments keep going into the subretinal space. And the retinal incarceration in the anterior wound also allows the instruments to go subretinally. So where the retina is coming in the way, you just cut off the retina in that quadrant so that the retina falls back and you fix it later. This video shows you about the cilio-choroidal detachment, which is causing, you can see with MVR blade, I'm incising the tip of the tissue or the tip of the 6 millimeter infusion cannula so that the tip can be burrowed into the vitreous cavity. That's the only way that can be brought into the vitreous cavity. The choice of the sclerotomy site is important in these cases. You avoid scleral scars, old scleral scars, because they are also likely to be having a retinal incarceration. You avoid previous sclerotomy sites if possible. If 23 gauge or 25 gauge is better than 20 gauge sclerotomy, because 20 gauge sclerotomy is more easily enlarged and merged with the old scleral injuries, while 23 gauge sclerotomy, especially with the trocar cannula system, don't enlarge sideways. You can choose odd locations such as an infusion cannula at the 12 o'clock or the inferior nasal infusion cannula, depending upon the requirement. So the location of sclerotomies can be chosen very precisely based upon the overall scleral integrity. Vitrectomy is thoroughly done, vitreous shaving is done, and special attention is done to the vitreous in the wound and the vitreous adherent to the iris both anteriorly and posteriorly. Very often we don't realize that a vitreous which is thrust with violence against the posterior surface of iris is stuck to the posterior iris as firmly as it can be to the anterior wound of the cornea. And even that can be a cause for traction on the peripheral retina. So even that has to be dissected carefully. You should manage the uveal tissue, including the suturing of the suturing of the cyclodialysis cleft. Because you are inside and vitrectomy has already been done, it's very easy to suture the cyclodialysis to the sclera by using a McConnell type of suturing. You can use multiple sutures depending upon the extent of dialysis. So this is just an IVH which requires 2 sutures to anchor the entire cyclodialysis cleft before we proceeded with the completion of vitreous surgery and whatever else is required. If the retina is okay, you can even put intraocular at the same time. The sutures of the intraocular also can be used to partially anchor the cyclodialysis cleft. So this is, you can see how the needle is being brought back. You can see the space in the cyclodialysis. You can see this whole thing is a space. And the needle is actually having difficulty in penetrating a floppy ciliary body. So you're using the second needle to push against the first needle so it can go through the ciliary body. Okay? That's how you can anchor it. You can also restructure the pupil at the same time if the iris or pupil in the body is torn by similar McConnell sutures. This is the second suture being placed for repairing the cyclodialysis cleft. Then you manage the retina, you clean the preretinal surface, and when I use the word clean, yes, you literally clean it. You don't leave any fibrous tissue sticking onto the retina. And then you access the subretinal space if need be and clean the same, even if it means you make a 360-degree retinotomy. Bimanual membrane peeling is needed if need be, and retinectomies may be needed. This is just one short video which shows the vitreous hemorrhage being removed, and you can see even when you cut the vitreous hemorrhage, you can realize that the hemorrhage is actually is emanating from the posterior pole, indicating it is incarcerated in the posterior pole where the retina also is incarcerated. So after removing this tissue, we also clean the entire periphery by using indentation, and then you realize that the whole retina is incarcerated there. Pre-retinal membranes are removed. Then you make a retinectomy around the area of incarceration using a combination of cautery and scissors or a cutter. This is all done in the era of 20 gauge vitrectomy, so you see the instruments are large and scissors are large. But with a 23 gauge cutter, you really don't need even a scissors. You can just cut it with the cutter itself. Then use perfluorocarbon liquids, lasers, and then put in silicone oil. So the causes for poor results are PVR and recurrent detachment. I don't take much time, Nataraj, just half a minute more. Hypotony that does not permit. So, so you think we have another lot of time to go, is it? Okay, anyway, we can use it for discussion. So the causes for poor results are mainly recurrent PVR. The reason is sclera is ruptured, choroid is injured, and these mixed with the blood in the eye is an excellent medium for fibrosis to take place. In fact, this is a beautiful study by Dr. Ron Michaels, then by Stephen Ryan, in pigs where they injected blood after injury, and they found the fibrosis is very severe compared to when you did not inject blood. So a mixture of blood, vitreous, sclerochoroidal trauma is the ideal medium for severe fibrosis to take place. And that is the reason why the surgery fails, because of recurrent retinal detachments. And another important cause for poor results, even after such heroic surgeries, is hypotony. The ciliary body never seems to recover, and these eyes don't regain enough pressure for you to remove the silicone oil, and then you end up with an unsatisfactory endpoint where the eye is soft, silicone oil filled eye, you can never remove the oil, causes corneal decompensation, etc., etc. And you can also have poor visual acuity despite anatomical success due to optic atrophy, corneal opacity, etc. So in summary, in 10 minutes time about traumatic detachments, this is all we can cover. Traumatic detachment can comprise a wide spectrum. Early surgical intervention before significant fibrosis gives you better results, and long-term results would depend on severity of initial damage, recurrence of PVR, and ciliary body function. Thank you for your attention.